Pulmonary contusion. Pulmonary contusion is observed in about 20% of adult patients with multiple traumatic injuries and in a higher percentage of children due to increased compliance of chest wall. It is defined as damage to the lung tissues resulting in hemorrhage and localized edema. It is associated with chest trauma when there is rapid compression and decompression to the chest wall. Example, blunt trauma. It may not be evident initially on examination but will develop in the post-traumatic period. Pathophysiology. The primary pathologic defect is an abnormal accumulation of fluid in the interstitial and intraalveolar spaces. It is thought that injury to the lung parenchyma and its capillary network results in a leakage of serum protein and plasma. The leaking serum protein exerts an osmotic pressure that enhances loss of fluid from the capillaries. Blood, edema, and cellular debris from cellular response to injury enter the lung and accumulate in the bronchioles and alveolar surface where they interfere with gas exchange. An increase in pulmonary vascular resistance and pulmonary artery pressure occurs. The patient has hypoxemia and carbon dioxide retention. Occasionally, a contused lung occurs on the other side of the patient point of the body impact. This is called countercop contusion. Clinical manifestations. Pulmonary contusion may be mild, moderate, or severe. The clinical manifestations vary from tachypnea, tachycardia, pleuritic chest pain, hypoxemia, and blood-tinged secretions to more severe tachypnea, tachycardia, crackles, frank bleeding, severe hypoxemia, and respiratory acidosis. Changes in sensorium, including increased agitation or combative irrational behavior, may be signs of hypoxemia. In addition, the patient with moderate pulmonary contusion has a large amount of mucus, serum, and frank blood in the tracheobronchial tree. The patient often has a constant cough but cannot clear the secretions. A patient with a severe pulmonary contusion has the signs and symptoms of ARDS, acute respiratory distress syndrome. These may include central cyanosis, agitation, combativeness, and productive cough with frothy, bloody secretions. Assessment and diagnostic findings. The efficiency of gas exchange is determined by pulse oximetry and arterial blood gas measurements. Pulse oximetry is also used to measure oxygen saturation continuously. The chest X-ray may show pulmonary infiltration. The initial chest X-ray may show no changes. In fact, changes may not appear for 1 to 2 days after the injury. Medical management. Treatment priorities include maintaining the airway, providing adequate oxygenation, and controlling pain. In mild pulmonary contusion, adequate hydration via intravenous fluids and oral intake is important to mobilize secretions. However, fluid intake must be closely monitored to avoid hypervolemia. Volume expansion techniques, postural drainage, physiotherapy including cuffing and endotracheal suctioning are used to remove the secretions. Pain is managed by intercostal nerve blocks or by opioids via patient-controlled analgesia or other methods. Usually antimicrobial therapy is administered because the damaged lung is susceptible to infection. Supplemental oxygen is usually given by mask air cannula for 24 to 36 hours. The patient with moderate pulmonary contusion may require bronchoscopy to remove secretions. Intubation and mechanical ventilation with PEEP may also be necessary to maintain the pressure and keep the lungs inflated. Diuretics may be given to reduce edema. A nasogastric tube is inserted to relieve gastrointestinal distension. The patient with severe contusion may develop respiratory failure and may require aggressive treatment with endotracheal intubation and ventilatory support. Diuretics and fluid restriction also needed. Colloids and crystalloid solutions may be used to treat hypovolemia. Antimicrobial medications may be prescribed for the treatment of pulmonary infection. This is a common complication of pulmonary contusion, especially pneumonia in the contused segment, because the fluid and blood that extravasates into the alveolar and interstitial spaces serve as an excellent culture medium. Thank you.